everyone, I'm Sarah Jackson and I'm a Principal Research Fellow within UCL's Tobacco and Alcohol Research Group. I'm going to take you through some of the evidence on how we can increase quit success in Cheshire and Merseyside. I'll cover different methods of quitting, including which routes to quit are the most effective, which are the most popular, and where there's potential to encourage people to move to a more effective method. So first, why do people want to quit? Well, there are a vast number of different reasons. The most common is concern for health. Over a third of smokers who try to quit say they're worried about future health problems, and around 1 in 5 want to quit because they already have health problems linked to smoking. Cost is another important reason. Smoking carries a substantial financial burden and is most common among disadvantaged groups with limited money to spend. Many people also report being prompted to try and quit by loved ones or advice from a health professional. Others decide to quit because of life events, in response to restrictions on smoking, or hearing about available support. But whatever the reason for trying to quit smoking, people tend to find it incredibly difficult to stop. So what's the secret? Well, as I'm sure you'll all know, there isn't one really. There's a massive amount of luck involved with stopping smoking. You could do everything right and you could still end up going back to smoking. You can do everything wrong and you could succeed. But an analogy we often use is that if you try to stop without any form of support, then you've got 2 dice and you've got to roll 2 sixes. Now some people might do it straight off the bat, it's just the law of averages. Some people roll the dice, get 2 sixes and think, well, that was easy, I can't understand what all the fuss is about. Other people keep rolling and they never seem to get the 2 sixes. But the point is that every time you try, it's another roll of the dice. The statistics tell us it makes no difference how many times you've tried to stop in the past to your chances of success this time. Each time you try and stop, it's another roll of the dice. So the way that we can help is to encourage people to keep rolling the dice and loading the dice in their favour. Today I'm going to focus on the latter, how we can increase the chances that a given quit attempt will be successful. In order for a quit attempt to be successful, you just have to keep these 2 lines apart. You've got your top-down resolve, the clever part of your brain saying, I really want to quit, I don't want to smoke. But because nicotine is addictive and abstinence triggers withdrawal symptoms, you've also got the craving, the urge, which in a given moment is telling you, just smoke. And as soon as that urge becomes stronger than your resolve not to smoke and cigarettes are available, a lapse will occur. So you've got to find some way of keeping those lines apart so that the resolve to not smoke is consistently greater than the urge to smoke. Well, the best treatment makes it much easier to achieve this. It's like taking one of those dice away. Now you've only got to roll 1 6, and the chances of getting 1 6 is obviously a lot greater than getting 2. And there are 2 main ways that support can help to keep these lines apart. The first is medications or non-combustible nicotine products, which help to dampen down the urge to smoke. These include prescription-only medications like varenicline, bupropion and cytosine, nicotine replacement therapies, which are available either on prescription or over the counter, and e-cigarettes. And the second is psychological or behavioural support, usually from dedicated stop smoking services, which helps to boost the resolve. Now, there have been hundreds of studies evaluating the effectiveness of different methods of quitting, and we have a pretty good idea of what works well and which are less effective. Cochrane reviews provide high-quality summaries of the state of the evidence on different smoking cessation interventions. The results are presented as risk ratios with 95% confidence intervals. And for those of you who are unfamiliar with these tell us how many times more likely people are to quit if they use a certain intervention versus a comparator, and how confident we are about that estimate. The data show there's high certainty evidence that different prescription medications are effective. Varenicline, also known as Champix, acts on nicotine receptors in the brain, and it's very successful at controlling cravings. It more than doubles people's chances of quitting successfully. Bupropion is also effective in increasing quit rates, but effects are not as strong as for varenicline. And cytosine, which has just become available on the NHS this year, works in much the same way as varenicline, and it appears to be similarly effective, although the evidence is currently low certainty as there haven't been many studies on this drug yet. Nicotine replacement therapies, things like patches and gums, are also effective at increasing success rates, although the effect is smaller than for varenicline at around 55%. NRT is more effective if you use 2 forms. Don't just use a patch, don't just use a gum, use a patch to release nicotine slowly and suppress cravings, plus one of the other faster acting products, something like a gum, a lozenge, an inhalator, to deal with acute cravings in the moment. This gives a better effect, closer to varenicline. And then we've got e-cigarettes, which are essentially another form of NRT, but with a much more similar behavioural action to smoking. There's high certainty evidence that e-cigarettes help people to quit, increasing the chances of success by around 60% as compared to traditional NRT. So we've got a lot of options for effective pharmacotherapy. And then in terms of behavioural support, there's evidence that smoking cessation counselling is effective. Effect sizes vary, but there doesn't seem to be a significant difference between individual or group-based counselling. And then when we put together the behavioural support and the pharmacological support, which is what Stop Smoking services deliver, we can substantially improve a person's chances of stopping smoking. High certainty evidence shows that this combination increases people's chances of quitting by around 83%. So this really makes a big difference to whether a quit attempt is successful. Now, clinical trials don't always translate to the real world, so it's important to look at observational data to confirm treatment effectiveness. We use data from the Smoking Toolkit study, which is a large representative survey of adults in England, to compare quit success rates among smokers using different methods of quitting, taking into account any differences in their characteristics that might make them more likely to use a certain method. So, for example, people who are more dependent are more likely to use varenicline in a quit attempt, but they're also less likely to quit successfully. So we adjust for level of dependence to avoid giving the wrong impression that varenicline causes reduced quit success. So in this analysis, we found that varenicline and e-cigarettes were the most effective quitting aids, with estimates of effect size in a similar ballpark to those from the clinical trial data. People who used these aids had almost double the odds of quitting successfully than those who didn't. Prescription NRT was also found to be effective. However, using NRT bought over the counter was not associated with increased success in quitting. Now, this is probably because when people are not given advice on how to use NRT, they don't generally use enough of it to suppress cravings, and they tend to only use a single form rather than a patch plus a fast-acting form. And face-to-face behavioural support was associated with a modest increase in quit success. So here we analysed pharmacotherapy separately, so this only gives an indication of the effect of the psychological element of the support provided by Stop Smoking services. Our data suggests that these effects are broadly similar across different subgroups of smokers. For example, we recently looked at differences by mental health status and found no evidence that any of these aids are more or less effective for people with a history of mental health conditions. So what this tells us is that we should be recommending the most effective methods of quitting to all smokers. So that's what's effective, but what do people actually use? Well, in the Northwest, as in the rest of England, the most common form of support used is e-cigarettes, which are used in around a third of all quit attempts. Now, this is good news, given that they're one of the most effective methods of quitting. This is followed by NRT bought over the counter, used in around 1 in 6 attempts. This is less good, given that NRT tends not to be effective when bought over the counter, without advice on how to use it to maximise its effectiveness. Prescription medications, on the other hand, which are known to be effective, are used in less than 1 in 10 quit attempts. Likewise, very few people report using face-to-face individual or group-based behavioural support, and fewer still, just 1.4%, 1 in every 70 smokers who tries to quit, use the gold standard of behavioural support and prescription medication. So what about the rest? Almost half of smokers use none of these methods of quitting. So clearly there's substantial room for improvement here. In thinking about how we could encourage people to use more effective methods, we need to consider feasibility as well as effectiveness. Among the most effective forms of support are Stop Smoking services, prescription medication and e-cigarettes. However, each has its own problems in terms of increasing the number of users. So while you have an increased budget to spend, Stop Smoking services have been cut drastically in recent years, and you're not going to be able to meet demand if all of these smokers suddenly started coming to services for support. So while it's important to raise people's awareness of and access to these services, we also need to think about other things we can be doing in the meantime to help boost quit rates. The most effective prescription medication, varenicline, has been unavailable since mid-2021 due to concerns about levels of nitrosamine impurities in the drug. Cytosine, which is a similar compound, has just become available earlier this year and can be used as a similarly effective alternative. And NRT continues to be available on prescription. So again, raising awareness of these options and their benefits in terms of suppressing nicotine cravings may help to encourage more smokers to give them a go. But not all smokers like the idea of using medications to stop smoking and may be reluctant to seek them out. E-cigarettes are by far the most popular quitting aid and are easily accessible to smokers at relatively low cost. But while evidence shows they're substantially less harmful than cigarettes, many smokers are not aware of this and think they're equally or more harmful, which may discourage people from using them as a method to quit. Recent data suggests that harm perceptions of e-cigarettes are as bad as they've ever been, with 57% of smokers in England thinking they're at least as harmful as smoking. The National Swap to Stop scheme aims to give out 1 million free e-cigarette starter kits to help smokers quit, which is likely to make a real difference to quit rates, but this scheme won't be successful if smokers don't want to use them. So a key thing you can do is to work on communicating accurate messaging around the relative harms of vaping compared to smoking to encourage people to give them a go. These actions are not only important for increasing quit success rates, but for tackling inequalities in smoking. Research has consistently shown that although smoking rates are higher among disadvantaged groups, disadvantaged smokers want and try to quit, but they're less likely to be successful. For example, in a study of over 100,000 adults in England, we compared people living in social housing with other housing types on a range of different smoking outcomes, including smoking prevalence, level of dependence, quit attempts, and use of support, taking into account differences in other factors between groups, such as their age, gender, and the region they live in. We found that adults living in social housing had more than double the odds of being a smoker compared with those living in other housing types. Current smokers living in social housing smoked on average 1 more cigarette per day and had 50% higher odds of smoking their first cigarette of the day within 30 minutes of waking, which suggests they had significantly higher levels of dependence. However, their level of motivation to stop smoking didn't differ significantly from those living in other housing types. Smokers living in social housing were slightly more likely to have made a serious attempt to quit in the past year than those living in other housing types, but they had 37% lower odds of remaining abstinent. So this suggests that disadvantaged smokers want to quit, they try to quit, but they struggle to do so successfully. So it's particularly important to offer smokers from disadvantaged groups who have the highest smoking rates and tend to be more dependent the best possible support to help them achieve their goals of stopping smoking. So a quick summary before I finish. There are a variety of effective forms of support that can increase the chances that a quit attempt will be successful. However, almost half of smokers try to quit without using any of them. This means that even if the quit attempt rate didn't change, you could substantially increase quit rates in Cheshire and Merseyside by encouraging smokers to use more effective methods of quitting. Key opportunities to do this include expanding delivery of support via stop smoking services, promoting the use of cytosine as an effective alternative to varenicline, and tackling widespread misperceptions about vaping to try and encourage smokers to switch to a less harmful alternative. So that's it from me. If you have any questions, please do feel free to get in touch.